the nipple and areolar complex, such as they've had a prior breast procedure before the reconstruction. Then we would lean towards placing the tissue expanders first and following it up by a second procedure for implants. And that's to decrease the risk of complications such as skin flap necrosis or nipple areolar complex necrosis.
Just some stats on prostate cancer. It is the second most frequent cancer among men and the fifth leading cause of death among men. In 2025, we estimate about 313,000 men will be diagnosed with prostate cancer and about 35,000 deaths. Most will be localized disease, and about 12.9% of men will be diagnosed with prostate cancer in their lifetime, but only 2.5% of men will die of prostate cancer.
Is that you focus on value, but only in the setting of patient care. Quite clearly, when we started on this journey, we realized it's a triangle. You got the provider, you got the insurance company, and you got pharma. But right in the middle, through the tunnel, is your patient. So your patient care comes first. So anything that we do to reduce cost has to be in the setting of making this journey worthwhile for the patient and the outcomes to be not compromised. So that's one thing we're not willing to compromise when we started this whole journey here.
And patients, a lot of the NCI academic centers are on the East Coast or West Coast, a few in the middle of the country. So it requires patients to travel vast distances, sometimes a couple of hours or even take a flight. And clinical trial participation is low. Academic centers see 15% or less of all patients, and nationwide only 7%, less than 10% of cancer patients enter clinical trial, and that falls short of the NCI goal of 10 to 12% participation.